Hello, my name is Navpreet Dillon, and today I will be presenting a case study on Crohn's disease. Crohn's disease is a type of inflammatory bowel disease which affects any part of the gastrointestinal tract, commonly involving the terminal ileum and colon. This disease affects no nutrient absorption sites in the gut, which become disturbed. And there's a gastrointestinal loss which decreases the amount of mucosal area available for absorption. And the exact cause of this disease is still unknown, but there is a genetic predisposition. Crohn's disease often commonly runs in the family. There are several genes that have been studied as etiological factors implicated in Crohn's disease, such as NOD2, IL-23R, and ATG16L1 genes that studies have shown to have an implication. Now, the frequent symptoms that we are seeing with this disease is diarrhea, which may be accompanied with a bloody stool, abdominal pain, nausea, and vomiting. We can also see weight loss happen as well. You know, that a lot of people, due to the inability to digest certain nutrients or not eat certain foods, will experience weight loss due to that nutritional absorption site disruption. Currently, there is no cure for the disease. And so let's get to the case study. So, a patient, a 25-year-old male with no previous medical history, presents to the emergency department. He presents with the following symptoms of abdominal pain, of a 7 out of a 10. It was a sudden onset. He was experiencing nausea, vomiting, and weight loss. The patient also has a 9-year history of cigarette smoking, and which is 1 pack per day. And is significant because smoking is a major risk factor for Crohn's disease. So initially, um, the diagnosis is considered gastroenteritis. He is started on intravenous empranozole and balavacin in the emergency department, and is discharged on oral medication including ciprofloxacin, metronidazole, and omeprazole. However, 1 month later, the patient presents again at the ED, but he has, along with the previous symptoms, he has new symptoms which include right iliac fascia pain, continued nausea, vomiting, and weight loss, and also is experiencing constipation for 2 days. So, upon physical examination, there was pain upon deep palpitation, but there was no tenderness. So, serology testing was performed, and CBC was normal. Liver function test was normal. Serum analysis was normal. Lipase test was normal. Um, ESR was slightly elevated, but the big serology test that showed calprotectin being over 1,000 micrograms per gram, and a normal calprotectin is round or less than 50 micrograms per gram. So we see a very high elevated calprotectin in this case. So upon imaging, CT, which is the first image that we see to the left, showed long segment mucosal thickening in the distal ileum. Arrows also showed enlarged lymph nodes on the right side of the bowel. And after the CT, the differential diagnosis that were considered were Crohn's disease, Castleman disease, intestinal tuberculosis, and lymphoma. So further imaging was ordered. The next thing was a colonoscopy. And the colonoscopy showed a friable mucosa. So A and B, which is the top two images, shows the cecum and the ileocecal valve. In these two images, there was mucosal edema and ulceration. Now, the bottom two images is of the rectum and the anorectal junction, and both these sections were normal. Now, we kind of want to remember where Crohn's disease, well, Crohn's disease can commonly occur across the gastrointestinal tract. It is commonly seen in the ileum, which we kind of do here see the mucosal edema and ulceration. So, after the colonoscopy, there was a um, after the biopsy was taken during the colonoscopy, and so a histopathology image is shown here on Figure 3, which shows the cecum with acute and chronic inflammation, with mucosal ulcerations and non-necrotizing granulomas. So IgG and IL-6 levels were normal, and the lymph node biopsy actually ruled out the Castleman's disease and lymphoma. So upon imaging and serology and the symptoms that the patient presented with, and ruling out the differential diagnosis, Crohn's disease was confirmed. So after confirmation of diagnosis, the patient was started on a 6-month course of corticosteroids and sulfonazole. Patient returned for a 6-month follow-up and reported complete remission of symptoms with no flare-up. And during that time, the patient had stopped smoking. And as stated before, that is very important in this case. Now, other medications that Crohn's patients can be um, treated with are biologics. When I worked at a clinic for IBD, I saw a lot of Crohn's patients, and biologics have become a commonly used treatment, especially when corticosteroids are not functioning and are not reducing remission of the symptoms, and flare-ups are still occurring. Another thing that actually is very important for Crohn's patients is lifestyle changes. So smoking, obviously, if you are a smoker, cessation of smoking is very important, but diet is also very important. I was a part of a clinical study in which we had patients with Crohn's given 30 grams of fiber per day over a 4-month period, and there was a remission of symptoms in that as well. And fiber is very important. It can reintroduce healthy microbiota to the gastrointestinal tract. There's a lot of research being done that Crohn's disease occurs because of that, because there becomes a lack of that healthy microbiota in the areas where Crohn's disease occurs. So reintroducing fiber can potentially increase that microbiota. And so diet is very important. And it kind of varies from patient for patient what type of foods increase flares and which don't. But reducing smoking, drinking, and introducing a high fiber diet is very important for Crohn's patients and can help reduce symptoms, since that is what treatment is focused on, since there is no cure for this disease. Thank you very much for listening, and here is my reference list that I used. Thank you very much.